Hello and welcome. Today we'll be exploring a major topic in post-cardiac arrest care, whether targeted hypothermia improves survival and functional outcomes in comatose patients after out-of-hospital cardiac arrest. This presentation will walk you through recent findings from the TTM2 trial comparing hypothermia to normothermia and what these results mean for our clinical practice. Let's dive in. In adult patients who are comatose following an out-of-hospital cardiac arrest, does the use of targeted hypothermia improve survival rates and functional outcomes compared to standard normothermia? Bottom line, main conclusion, targeted hypothermia did not show improvements in survival, functional outcomes, or quality of life for these patients when compared to normothermia. Key side effect, hypothermia was associated with a higher incidence of arrhythmias. Background and prior evidence, HACA trial, 2002. Early evidence suggested targeted hypothermia, 33 degrees Celsius, improved survival and neurologic outcomes in patients with shockable rhythms, VF, pulseless VT. Hyperion Study 19 showed potential benefits of hypothermia, 33 degrees Celsius versus 37 degrees Celsius, in patients with non-shockable rhythms. Cochrane Review, 2012. Mild hypothermia may enhance survival and neurologic recovery in cardiac arrest patients. TTM trial 2013 found no significant survival or neurologic outcome differences between patients treated with hypothermia versus normothermia 36 degrees. TTM2 trial design. Study design, randomized multicenter, open-label, blinded assessment trial to evaluate if hypothermia offers a survival advantage. Participants, 1,861 adult patients, all with coma post-out-of-hospital cardiac arrest. Intervention group, hypothermia group, target temperature of 33 degrees Celsius maintained for 28 hours, then rewarming at 1/3 degree per hour until reaching 37 degrees Celsius. Normothermia group, temperature kept at 37.5 degrees Celsius, using cooling methods if it rose 37.8. Time period, conducted between 2017 to 2020, across 61 centers in 14 countries. Study out primary outcome, all-cause mortality at 6 months. Result, mortality rate was 50% in the hypothermia group versus 48% in the normothermia group. RR 1.04, p equals 0.37, indicating no significant difference. Secondary outcomes, functional outcome. Modified Rankin score of 4 to 6 was 55% for both groups, showing no difference. Quality of life, EQ5D5L, no meaningful difference between groups, with only a -0.8 point difference. Poor functional outcome at 6 months, similar at 54% in both groups. Subgroup and adverse event analysis. Subgroup analysis, no significant difference observed by sex, age, initial cardiac rhythm, time to return of spontaneous circulation, ROSC, or shock on admission. Adverse events, arrhythmias, 24% in hypothermia versus 16% in normothermia. Significant increase with hypothermia, p 0.001. Bleeding, similar rates in both groups, 5%. Pneumonia, comparable rates at 36% in hypothermia and 35% in normothermia. Sepsis, slightly higher in hypothermia, 11% versus 9%, though not statistically significant. Limitations of the study, impact of COVID-19, some follow-up assessments were conducted via telephone with caregivers, potentially affecting accuracy. Open-label design. Lack of blinding may have led to unconscious treatment bias by clinical staff. Absence of a control group. The study only compared hypothermia with normothermia without a no-intervention control. Concomitant care. Not protocolized, potentially influencing outcomes. Co-enrollment in TAM trial. 20% of patients were also enrolled in the targeted therapeutic mild hypercapnia after resuscitated cardiac arrest trial, which may have introduced additional variables. Conclusions and clinical implications. Evidence level. High-quality data from this large multicenter trial suggests that targeted hypothermia does not improve outcomes for comatose cardiac arrest patients. Clinical considerations. Hypothermia requires intensive monitoring and carries risks like arrhythmias, sedation requirements, and potential metabolic disturbances. Guidelines. No updated clinical guidelines currently reflect these findings as of August 2021. This may impact future guidelines for post-cardiac arrest care. This presentation highlights the critical aspects and findings of the TTM2 trial. offering evidence for practice considerations in post-arrest care.